Specific methods of definitive fracture treatment. Specific methods of definitive fracture treatment. Knowledge of indications and contraindications is great importance. Three main situations that represent a contraindication for a specific method of treatment. 1. The fracture is not sufficiently serious to require the method. 2. The fracture cannot be adequately treated by the method. 3. Either the patient or the fracture is likely to be made worse by the method. Bear in mind the four basic goals of all fracture treatment. 1. To relieve pain. 2. To obtain and maintain satisfactory position of the fractured fragments. 3. To allow, and if necessary, encourage bone union. 4. To restore optimum function, not only in the fractured limb or spine, but also in the patient as a person. Swiss AO versus American Functional Bracing System. Preservation of the function in the injured limb. Prevention of the fracture disease. Specific methods of treatment for closed fractures. 1. Protection alone, without reduction or immobilization. Protection from usual forces to bone. In upper, single sling. In lower, crutches. Indications: undisplaced or relatively undisplaced stable fractures of the ribs, phalanges, metacarpals, clavicle in children, that is undisplaced and stable fractures. Mild compression fractures of the spine, impacted fractures of the upper end of humerus. After clinical union has been obtained by other means, but before radiological consolidation. Risk: may not adequate for certain patients. For example, very young child or uncooperative adult that needs radiographic examination over the course of the healing process. From the topic we've discussed before, the first picture shows protection alone without reduction or immobilization. Simple sling for an upper limb injury and crutches with no weight bearing on an injured lower limb. The second picture shows fractures that can be treated by protection alone. Picture A: crush fracture of the distal phalanx. Picture B shows undisplaced fracture of the metacarpal. Picture C is green stick fracture of the clavicle in a young child. Picture D is impacted compression fracture of the surgical neck of the humerus in an elderly adult. Picture E is undisplaced fracture of ribs 7th, 8th, and 9th. Picture F shows mild compression fracture of the thoracic spine. 2. Immobilization by external splinting or without reduction. Indications: fracture that relatively undisplaced yet unstable. Long bone fracture with only sideways shift but could contact and no significant angulation or rotation. Risk: subsequent pull from muscles and gravity causes further displacement, such as angulation, rotation, overriding that is unacceptable. Repeated radiographic examination, at least during early stages of healing. Pressure sores over bony prominences. Constriction of a limb with resultant venous or arterial impairment. So, the first picture shows immobilization by external splinting or without reduction. Plaster of Paris cast of varying design. Picture A is body cast, used more for children than for adults. Picture B is above elbow cast. Picture C is hip spica cast. Picture D is below knee walking cast. The second picture shows fractures that can be treated by external splinting or without reduction. Picture A is undisplaced fracture of the radius and ulna of a child. Picture B is undisplaced fracture of the neck of the radius in a child. Picture C is oblique fracture of the shaft of the humerus in an elderly lady. Notice the metallic corset stays. Did you notice the second fracture? There is a coexistent impacted compression fracture of the surgical neck of the humerus. Picture D is stable transverse fracture of the tibial shaft. Picture E is compression fracture of the second lumbar vertebra. The lumbar spine is more mobile and less stable than the thoracic spine. 3. Close reduction by manipulation followed by immobilization. Form of surgical manipulation, by far the most common method of treatment. Reduce under anesthesia, immobilized by means of a POP, usually involves placing fracture fragments where they were at the time of maximal displacement, then reversing the path of displacement. Indications: displace fracture that require reduction and can be reduced and maintained by closed means. Risk: if anaply applied, may cause further damage to soft tissues. Excessive traction in the longitudinal axis, atelia spasm, Volkmann's ischemia, or particularly at the elbow and knee. Progressive swelling of a limb within tight and rigid cast, Volkmann's. Pressures source over bony prominences. Oblique, spiral, and comminuted fractures may become displaced. Radiograph. From the topic we've discussed before, this picture shows close reduction of a fracture by manipulation. Picture A is fractures of the distal end of radius and ulna with angulation and overriding in a child. Picture B shows longitudinal traction corrects the angulation but doesn't reduce the fractures because the intact periosteal hinge will not allow the fracture fragments to be distracted sufficiently to obtain reduction. These radiographs were taken for teaching purposes. Normally, the surgeon's hands would not be exposed to the radiation. Picture C is the fracture deformity must first be increased to the extent that it was with the maximum displacement at the very moment of the fracture occurring. Then the distal fragment can be moved distally so that the fracture surfaces can be engaged. Only after this manipulation to correct the overriding is angulation corrected. The intact periosteal hinge on the concave side of the angulation then prevents overcorrection of the fracture deformity. Picture D shows the reduced fracture is ready to immobilize in a well-molded plaster cast that will maintain the reduction. This picture shows fracture that can be treated by closed reduction followed by immobilization. Picture A is displaced fractures of the distal end of the radius and ulna of a child. Picture B is closed fracture of the distal end of the radius of an adult. Picture C is greenstick fracture of the shaft of the radius and ulna of a child. Picture D is displaced supracondylar fracture of the humerus in a child in whom percutaneous pinning is added. Picture E is angulated spiral fracture of the tibial shaft in an adult. 4. Closed reduction by continuous traction followed by immobilization by means of skin traction in young children and skeletal traction in adult. Fixed traction versus balanced traction may require manipulative reduction priorly. After the fracture has healed to the point of becoming sticky and non-tender, it can be replaced by appropriate cast. Indications: unstable oblique, spiral, or comminuted fractures of major long bones, unstable spinal fractures, fractures that can encircling bandage or cast is dangerous in vascular injuries, excessive swelling, skin loss. Risk: excessive longitudinal traction may cause arterial spasm. Volkmann's. Skeletal traction, pin track infection, failure to achieve and maintain adequate reduction, distracted too far, delayed union or non-union, for economic reasons has been largely been replaced by early external or internal skeletal fixation with or without open reduction. From the topic we've discussed before, the first picture shows continuous skin traction. Picture A is continuous fixed skin traction combined with a Thomas splint for a boy with an unstable fracture of femur. Picture B shows continuous balanced skin traction of the arm for a boy with an unstable fracture of the humerus. Note also the skeletal traction on the femur for an unstable subtrochanteric fracture of the femur in the same boy. Although these traction methods are both safe and sound, they have been replaced to a large extent in an era of cost constrained by cooperative methods that enable the child to be discharged from the hospital within days rather than weeks. The second picture shows continuous skeletal traction. Picture A shows continuous skeletal traction through the olecranon for an unstable supracondylar fracture of the humerus in a child. An alternative that has become popular for such a fracture is close reduction combined with percutaneous pinning. Picture B shows continuous balanced skeletal traction through the upper end of the tibia for an unstable fracture of the femur in an adult. For fractures of the femur in adults, continuous traction may be used temporarily but has to a large extent been replaced by either external or internal skeletal fixation. Picture C shows continuous skeletal traction through a halo attached to screws in the outer table of the skull for an unstable fracture dislocation of the cervical spine. This picture shows fractures that can be treated by continuous traction. Picture A shows unstable comminuted fracture of the shaft of the humerus. Picture B is unstable fracture of the shaft of the femur. Picture C is unstable comminuted supracondylar fracture of the femur. Picture D is unstable fracture dislocation of the cervical spine, which would be followed by a local spinal fusion after reduction of the dislocation. 5. Close reduction followed by functional fracture bracing. Based on the following concepts. 1. Rigid immobilization of fracture fragments is unnecessary and may impair healing. 2. Function and resultant controlled motion actually stimulate healing. 3. Such function prevents iatrogenic joint stiffness. 4. Somewhat less than perfect reduction of the fracture of long bones doesn't create significant problem. The initial, close reduction or continuous traction followed by POP for 3 until 4 weeks, later hinge brace. Indications: fractures of shaft of the tibia, distal third of the femur, the humerus and the ulna in adults. Contraindications: fractures that can be more effectively treated by ORIF, for example, intertrochanteric and subtrochanteric fracture, mid-shaft fracture of the femur, shaft of the radius, and intra-articular fractures. Risk: relatively risk-free, but failure to maintain an acceptable position of the fracture management. The first picture shows functional fracture brace for a fracture of the shaft of the tibia in an adult. Note that the well-molded and close-fitting plastic or orthoplast brace allows full motion of both the ankle and the knee, and in this sense is much more functional than a plaster cast that immobilizes both joints. Picture 2 shows functional fracture brace for a fracture of the distal third of the femur in an adult. Note that the brace, which has a metal hinge at the knee and a plastic hinge at the ankle, allows motion at the hip, knee, and ankle. 6. Close reduction by manipulation followed by external skeletal fixation. Modified from fat, pins and bars, Hoffman type, Elizarov frame. Indications: severely comminuted and unstable fracture of the shaft of the tibia or femur, especially GA3 with extensive injuries to the soft tissues. Other unstable fractures of the pelvis, humerus, radius, and metacarpals. Risk: pin tract infection with or without osteomyelitis, ring sequestrum if high-speed power drill is used. From the topic we've discussed before, the first picture shows simplest form of external skeletal fixation to provide fixation of a comminuted fracture of the tibia at a distance. Picture 2 shows more sophisticated form of external skeletal fixation to provide more rigid fixation in 3 dimensions. 7. Close reduction by manipulation followed by internal skeletal fixation. Accurate manipulative close reduction maintained by percutaneous insertion of metallic nails or iron rods across the fracture site. Both blind, confirmed by radiographic control. Indications: only for certain fractures in which accurate reduction can be obtained by close means, but cannot be maintained by external immobilization. For example, unstable fracture of the column femur, certain fracture of the mid-shaft of the long bones. Risk: may fail to obtain satisfactory position of the fracture fragments. May fail to achieve sufficiently rigid fixation of the fracture. Risk of infection. From the topic we've discussed before, the first picture shows closed reduction followed by internal skeletal fixation. Picture A is 3 cannulated screws that have been inserted blindly and percutaneously across the fracture of the neck of the femur after closed reduction. This so-called blind pinning of a fracture is not really blind. It is performed under radiographic control. Picture B is intramedullary rod that has been inserted percutaneously across a segmental fracture of the shaft of the femur after closed reduction. The second picture shows fractures that can be treated by closed reduction and internal skeletal fixation. Picture A shows fracture of the neck of the right femur in an adult. Picture B shows fracture of the neck of the left femur in a child. A. Open reduction followed by internal skeletal fixation. Should never be undertaken lightly. When the results are good, they are very good. But when they are bad, they are catastrophic. The fracture site, exposed surgically and reduced under direct vision, should be performed under ideal condition, experienced surgeon, infection-free operating theater. The reduction then maintained by internal fixation aka osteosynthesis, screws, plates, IM nails and rods, pins, bands, wire sutures. Usually after the union is achieved, the devices are removed, but apparently not so nowadays. AO system. To achieve internal fixation of the fracture fragments rigid enough that external immobilization is not necessary and full active function of muscles and joints is possible soon after the operation. To prevent fracture disease, sequelae of prolonged limb immobilization, joint stiffness, muscle atrophy, disuse osteoporosis, and chronic edema. A. Open reduction followed by internal skeletal fixation. Indications. When reduction or and maintain the reduction is impossible by close means displaced avulsion fractures, intra-articular fracture, epiphyseal fracture, fracture plus trapped soft tissues including vascular, intertrochanteric fractures of the femur, fractures of both bones of the forearm in adults, displaced fractures of the phalanges. Other indications facilitate nursing care. Elderly, severe head injury, spinal injury, pathological fracture. Contraindications: fractures of the shaft of the tibia and humerus. Close nailing or bracing is better. Risk: open to inspection, same as open to infection. Damage to the blood supply. Metal failure. Postoperative adhesions of muscles. This picture shows metallic devices used for internal fixation of fractures. Picture A is interfragmentary transfixion screws for a long oblique fracture of the tibia. Picture B is leg screw or compression screw for an avulsion fracture of the medial malleolus. Picture C is heavy onlay compression plate and screws or AO compression device for fractures of the radius and ulna. Picture D is intramedullary rod for a segmented fracture of the femur. Picture E is nail plate combination for a fracture of the neck of the femur. Picture F is Kirschner wire of a fracture of the lateral condyle of the humerus in a child. Picture G is intramedullary Kirschner wire and a tension relieving figure 8 wire loop or AO device for a fracture of the olecranon. This picture shows fractures that are best treated by open reduction and internal fixation. Picture A shows fracture of the shaft of the radius and subluxation of the inferior radial ulnar joint in an adult. Picture B is fracture of the shaft of the ulna and anterior dislocation of the proximal end of the radius in an adult. Picture C is widely separated intra-articular fracture of the olecranon. Picture D is displaced fracture of the lateral condyle of the humerus in a child. Picture E shows fracture subluxation of the ankle with an avulsion fracture of the medial malleolus and a comminuted fracture of the shaft of the fibula. Picture F shows comminuted intertrochanteric fracture of the femur. 9. Excision of a fracture fragment and replacement by an endoprothesis. For certain fractures of the hip and elbow, the results of internal fixation are unsatisfactory due to high incidence of AVN, non-union, and post-traumatic OA. The articular fragments may be excised and replaced by other prostheses. Indications: fracture of the neck femur in the elderly, comminuted fracture of the radial head or contraindicated in children, severely comminuted fractures of the patella, comminuted fracture of the humeral head, breast, infection and migration of the endoprothesis. From the topic we've discussed before, the first picture shows excision of a fracture fragment and replacement by a prosthesis. In this elderly patient who had a femoral neck fracture, the proximal fragment or femoral head and neck has been excised and replaced by an endoprosthesis, or in this case a cemented hip prosthesis, the stem of which penetrates the distal fragment. The second picture shows fractures that may require excision of a fragment. Picture A is fracture of the femoral neck in an elderly adult. The femoral head fragment should be replaced by an endoprosthesis. Picture B shows severely comminuted intra-articular fracture of the radial head in an adult. Picture C shows severely comminuted or shattered patella. The wound varies considerably. Maybe a small puncture wound from within by bone, maybe from without by a missile, for example bullet. The soft tissue injury associated usually even more extensive than immediately apparent. The external blood loss associated with is also frequently underestimated. From the topic we've discussed before, the first picture shows open fracture of the distal end of the tibia. The protruding tibial fragment has penetrated the skin from within, and the skin has been further torn by severe displacement at the moment of the injury. Second picture shows open fracture of the shaft of the tibia. The blades of a power lawn mowers penetrated the skin from without and fractured the tibia. There is extensive soft tissue loss as well as loss of a large segment of bone. Notice also the associated closed fracture of the fibula. This picture shows an open fracture of the distal end of the femur and proximal end of the tibia in a child. A power saw has lacerated and avulsed skin and has cut out a portion of the femur and tibia. Picture B shows clinical appearance of the limb showing the extensive skin lacerations, avulsion of skin, extensive damage to underlying soft tissues and bones. Picture C shows after debridement and partial closure of the wound, the residual skin deficit was covered later by a split thickness skin graft. Picture D shows 1 year later. There is extensive scarring but good function. Nevertheless, further reconstructive surgery will be required because of an inevitable growth disturbance in the injured epiphyseal plate or physis. Classifications: Gustillo and Anderson. Type 1. A clean wound less than 1 cm in length, usually from within. Little soft tissue injury. Type 2. A laceration more than 1 cm in length, but without extensive soft tissue damage, skin flaps or avulsions. Type 3 is extensive soft tissue damage, such as skin flaps, avulsions, and muscles and nerves injury. 3A is extensive soft tissue damage but adequate bone coverage, segmental fracture, gunshot wounds. 3B is extensive soft tissue damage with extensive periosteal stripping, requires skin flaps or free grafts. 3C is associated vascular injury requiring repair. Primary closure for type 1 and 2. Infection rate of type 1 and type 2 is 2.4%. Delayed closure plus antibiotics for type 3 and infection rate of type 3 is 10%. Principles of treatment. Cleansing the wound. All foreign material should be washed away by extensive pulsatile irrigation and mechanical cleansing with saline or sterile water. Excision of devitalized tissues or debridement. All dead tissues should be excised. Should obtain a culture of the wound. Treatment of the fracture, either by skeletal traction, open reduction with internal fixation or external fixation should be adjusted with the characteristic of the fracture. Closure of the wound. It is recommended to delay the closure of the wound after the first 4 until 7 days, provided the infection has not developed. Antibacterial drugs should be administered in large dose before, during, and after treatment. However, surgical care of the wound is better than antibacterial drug. Prevention of the tetanus, TT with or without tetagum or HTIG. Other important things. Anesthesia for patients with fractures. During the first hour, the patient's tissue are somewhat numb. May be possible to reduce without anesthesia, only for the experienced and confident or one shot. Colds may be reduced after infiltration of a local anesthetic agent. Other regional limb block, brachial plexus, upper limb spinal, and lower limb. In general, best is under general anesthesia due to complete comfort and muscle relaxation. Rest of aspiration due to cease of gastric mobility after the fracture. Best wait at least 6 hours after injury. Temporarily spleen should not be removed nor the fractured part be moved during the preliminary stage of anesthesia. Painful stimulus, rest of cardiac arrest of laryngeal spasm. Aftercare and rehabilitation for patients with fractures. The most important is to restore optimum function. The more function that can be preserved during the treatment, the less function that has to be restored. The rehabilitation begins with the immediate care of the fracture through emergency treatment, definitive treatment, and beyond until the function is restored to normal, or at least near as normal as before. Appropriate elevation of the fractured limb to prevent joint stiffness. All muscles and joints that are not immobilized should be moved by the patient. Isometric and isotonic exercises. Patient minds is psychological considerations. The first picture shows supervised physiotherapy. The physiotherapist is teaching and encouraging the patient who has a fracture of radius and ulna to actively move all joints in the fractured limb that are not immobilized. The second picture shows supervised occupational therapy. The occupational therapist is retraining and encouraging this patient who is recovering from a closed fracture of the distal end of her radius in activities of daily living appropriate for her occupation as a homemaker. Classifications of complication of fracture treatment. 1. Skin complications. Tattoo effect from abrasions, pressure lesions or pressure sores such as bed sores and cat sores. 2. Vascular complications, traction and pressure lesions, Falkland's ischemia, gangrene and gas gangrene, DVT and PE. Neurological complications such as traction and pressure lesions. 4. Joints complications, septic arthritis. 5. Bony complications, osteomyelitis. Recognition and treatment of complication from both the initial injury and its treatment. The total care of the injured must include constant diligence and vigilance. Every complaint of the patient must be attended and examined clinically. When necessary, proceed with special investigations. Initial and early complications. Local complications, such as skin complications, vascular complications, such as arterial complications, and venous complications. Neurological complications, visceral complications, joint complications, such as septic arthritis, bony complications, such as osteomyelitis, and avascular necrosis of bone. Remote complications, such as fat embolism syndrome, pulmonary embolism, pneumonia, tetanus, and delirium tremens. Skin complications, abrasion with particles of dirt grounded to the dermis, if left uncleansed, will cause tattoo effect. Lacerations, puncture wounds, penetrating missile wounds, avulsion of skin and skin loss, common in open fracture. Gross swelling, result in blister or bleb. bed sores and cast sores due to constant compressions. It's preventable. The first picture shows tattoo effect from residual pigmented dirt that should have been removed from the abrasion during the clinical treatment and is now covered by epithelium. This unsightly blemish is preventable. Second picture shows blisters or blebs in the skin of the forearm in association with a fracture of the radius and ulna. One bleb has ruptured and the other is seeping serum. The first picture shows bed sore of the heel in an elderly comatose patient. This lesion is preventable by frequent turning on the patient by the nursing staff. The second picture shows pressure sore over the lateral aspect of the leg from excessive local pressure of the inaptly molded plaster cast. This iatrogenic complication, which is preventable by appropriate padding and molding, required a skin graft. Vascular complications. Arterial complications. Usually small vessels are torn at the time of all fractures. Injury to major artery is uncommon, particularly serious because of the sequelae of persistent arterial occlusion. Arterial division. A major artery may be completely or incompletely divided. Completely usually retracts and stops bleeding. Incomplete, continued bleeding may lead to the development of pulsating hematoma, residual hematoma locally and ischemia distally. Arterial spasm. When subjected to sudden and severe traction, persistent spasm, occlusion, ischemia, usually tear in the intima or thrombosis. Secondary arterial spasm, proximally and distally, even more extensive ischemia. Vascular complications. Arterial compressions. Occasionally, major artery becomes trapped and compressed between two fragments of fracture. Also can be iatrogenic, excessive tight POP or bandage and progressive swelling. Arterial thrombosis. Potential sequelae of any arterial injury. Higher risk in pre-existing arteriosclerosis. Recognition of arterial complications. Internal hemorrhage is less obvious than external hemorrhage, usually only by progressively enlarging local swelling. Complete arterial occlusion, initial pallor, loss of pulse, coolness of skin, later gangrene. Doppler of arteriography is useful, but do not delay surgical exploration. Vascular complications. Compartment syndrome. Increased pressure of progressive edema with rigid osteofacial compartment, either in forearm or leg. When intracompartmental pressure is high, it can increase the content of a given compartment or decrease its volume. Usually flexor compartment of the forearm and the anterior tibial. Progressive intracompartmental pressure compromise capillary blood flow to muscle. More edema, fissure cycle is established. Nerve can survive up to 2 until 4 hours. Muscles up to 6 hours but cannot regenerate. If left untreated, it can be compartmental contracture. May be secondary to 1. Proximal or extracompartmental occlusion of the main artery supplying the compartment. 2. Intracompartmental injury to either bone, soft tissue, or both with resultant hematoma. Vascular complications. Compartment syndrome. Most frequently occur in displaced supracondylar fractures of the humerus and damage to the brachial artery in children. Excessive longitudinal traction in the treatment of the femoral shaft fracture in children. Fractures of the proximal third of the tibia. Drug-induced coma with resultant pressure on major arteries from lying on hard surface in awkward position for a prolonged period. Clinical picture. Severe pain after pain-free interval. Passive stretch pain may be masked by large dose of analgesics. Pallor due to transient decrease in peripheral circulation. Puffy swelling of the hand or foot. Disturbance of involved peripheral nerve function, aka pain, pallor, puffiness, paresthesia, pulseless. Recently, it is possible to measure the intracompartmental pressure. Normal 0 until 8 mmHg. More than 30 until 40 mmHg is indication of immediate decompression. Must be left open at least 7 days, after which delayed primary closure can be performed. From the topic we've discussed before, the first picture shows sites of vascular complication in relation to fractures. Second picture shows impending gangrene of the foot and distal part of the leg in a 15-year-old boy who had sustained a closed fracture of the proximal end of the tibia. No pulse could be detected below the knee, and the skin was cool with mottled dark discoloration. The third picture shows the value of arteriography in vascular occlusion. Picture A is the knee region of a 15-year-old boy with a relatively undisplaced fracture of the proximal end of the tibia and fibula. The fracture, which was said to have been angulated, had been reduced 8 hours previously. The foot immediately became white and pulseless. The appearance of the boy's foot on admission is shown in figure. Picture B shows an arteriogram immediately after admission reveals the exact site of vascular occlusion just distal to the bifurcation of the popliteal artery. Exploration of the arteries was performed forthwith. The arteries were decompressed, after which blood flow was restored. The boy's foot did not become gangrenous, but because of the 8-hour delay before arterial exploration, he did develop Volkmann's ischemia of the leg muscles requiring fasciotomies. The last picture shows Volkmann's ischemic contracture of muscles of the forearm in a 6-year-old child. After reduction of a supracondylar fracture of the humerus, the child had complained of severe pain in the forearm. Regrettably, his surgeon prescribed large doses of analgesic that relieved the pain somewhat. In the meantime, the child developed severe Volkmann's ischemia of nerves and muscles in the forearm. In these photographs taken 6 months later, it is apparent that he has severe deformities and serious disability as a result of progressive contracture of the necrotic muscles that have been replaced by fibrous tissue. This tragic outcome could have been prevented by early recognition of this serious complication, removal of all encircling bandages and casts, fasciotomies, and stabilization of the supracondylar fractures by percutaneous pinning. Treatment of vascular complications. Occlusion of major artery is surgical emergency. Precedence over treatment of the associated fracture itself. 1. Constructing cast or bandage must be completely removed, not just cut. 2. Any distortion of the fractured limb or extreme position of a nerve joint should be lessened. 3. If the fracture is being treated by continuous traction, the amount of traction should be decreased. 4. If this failed, emergency arteriogram, no improvement within half hour, explore surgically. Divided artery should be directly sutured or grafted using venous graft or plastic prosthetic. Thrombus removed, compress, release, contuse or intimal tear, resect plus restore continuity, persistent spasm, dilate. Thank you.